So Theresa is a board certified specialist in swallowing and swallowing disorders. She is also a senior speech language pathologist at Stanford Healthcare in our head and neck oncology clinic and an adjunct professor at San Jose State University. She is one of the co-founders of the Bay Area Swallowing Support, or BASS group, providing support resources to patients with dysphagia. Her clinical and research interests include head and neck cancer rehabilitation, swallowing and voice disorders, and aphasia. She is passionate about serving people from diverse backgrounds with communication and swallowing problems, and has always been a strong advocate for her patients and profession. So,
thank you. Let's get started here. Okay. Thank you, Heather, and thank you everyone for coming today to our Dysphagia Awareness Symposium. As Heather already introduced, my name is Theresa. I work here at Stanford. This is a presentation that I developed with my lovely colleague, Jocelyn Hamilton, who can't be here today, unfortunately, because we're really passionate about this whole person approach to dysphagia. And Heather already mentioned, had a great presentation to start with to give us a good picture of how we wanted to treat patients with dysphagia using a whole person approach. So here are our disclosures. So here are our learning objectives from this talk. We hope that everyone can learn this framework that we proposed. It's called Living with Dysphagia, Living with Swallowing Difficulties, Framework of Outcome Measures, also called SWOFROM. And then we would discuss some of the patient-reported outcome measures and also some clinical tools to facilitate the use of this framework. And of course, we wanted to hope that everyone can apply this SWOFROM to your clinical practice. So to start with, we all know that dysphagia is not uncommon. In the United States, there's 1 in 25 adults with will experience dysphagia every year. And dysphagia can come from different etiologies and diseases such as stroke, dementia, Parkinson's, and head and neck cancer, and more. So people with dysphagia may experience psychosocial or physical challenges. So here's a quote I want to share with you. It pointed out that eating and swallowing is also a way for us to communicate and connect with people. So think about the major holidays here. We have, everyone gets together and then we connect with families and friends. And in that situation, what if you could not eat or enjoy eating and drinking? What if you had to be on a special diet or be on feeding tube? That's devastating. So recently, Dr. Rebecca Smith and colleagues have published several papers focusing on the impact of dysphagia on quality of life. And these are great papers. I think Heather also mentioned one. So there are 3 quotes that I wanted to share with you here from this paper. So it says the need for a healthcare professional there's a need for healthcare professionals to include social participation and well-being as part of the dysphagia intervention. And we need to engage in open communication with client, eliciting stories that look beyond the physical health to determine how exactly dysphagia is influencing the person's lifestyle. And they mean the healthcare professionals, also need to be aware of their positioning as healthcare professionals in perpetuating and ameliorating negative impacts on the person's quality of life brought about by assuming that dysphagia interventions would improve quality of life by improving health. So when we look at our current model of dysphagia treatment, it's mostly impairment-based management because we focus on managing the deficits. And in our evaluations, we always look for assessment and treatment on patients' anatomical or physiological changes. But should we view dysphagia as purely technical? The answer is absolutely not. It's important to remember that dysphagia is more than just physical difficulties. Sometimes we're too focused on just the disease and deficits and forget about that in front of us is not just the patient, they are also people. So they're people first, then patient. That's why it's really crucial to shift our focus to this whole person care. And we know that there's this mismatch, like what we're treating is not the whole picture. So that's why we're here to share some tools to help us to find the missing picture, and then also help us to broaden our lens to see dysphagia more than just the physical changes. So here, Heather also mentioned that this is the well-established framework from World Health Organization, the ICF. I believe a lot of you already heard this so many times. This framework basically combines the social and medical model together to view health through the lens of different health-related domains, such as the body structures, function, and that's the one that we are pretty familiar with. And then also activity, participation, and also some contextual factors like environmental factors and personal factors. And I believe many of us have worked with people with aphasia, and we probably heard this life participation approach to aphasia model, LPAA. So LPAA is a very, it's an excellent example of a philosophy of intervention that aims to help individuals live well with aphasia. And it focuses on re-engagement in life for patients with aphasia. So over several decades, there's a growing body of literature and evidence showing that this LPAA model of intervention is very effective to help individual living really well with their chronic aphasia. So based on this LPAA model and also the ICF model, there is this living with aphasia framework of outcome measures, A-FROM, that's developed by Dr. Kagan and colleagues. And this diagram on the right showed this framework, the A-FROM, which include the severity of aphasia, which is the impairment, and then personal identity, attitude, and feelings, and that's the personal factor, participation, and also the environment here. And then in the middle is living well with aphasia. So just a little bit background why we started to talk about this framework. Jocelyn and I, we both worked with patients with aphasia before. Before we joined Stanford, Jocelyn was in University of Iowa teaching students in the neuro clinic. So they applied this LPAA model a lot. And I also worked with a patient with aphasia at Cal State East Bay as a clinician for the aphasia treatment program. So we both love this model. And when we came here to Stanford, we started talking because we wanted to see if it's possible to use this model to our patients with dysphagia from head and neck cancer treatment. So we clicked, and then we changed this model to living with swallowing disorders, swallowing difficulties framework for outcome measure SWAL-FROM. So you can see here, it's basically the same diagram. And there's impairment, personal factors, participation, environment. And then we also added an outer layer, a circle of family and caregiver domain. And then this makes up this whole SWAL-FROM framework. So in the middle, we talk about this is life, just like the LPAA model. It basically aims at living well with dysphagia. So the reason we wanted to look at all the domains is because we really wanted to help the patient and caregiver to find the best way to live their best life. So remember, it's about them, it's about the patient and caregiver, not just us as clinician. So this brings this very great article published in ASHA 613 Perspective by Ambrosio and Shun in 2022, talk about this backward design model. This is basically a really good tutorial that guides you to rethink your process of designing your assessment and treatment, because we usually try to come up with the assessment and treatment for patients before we know them. But this model suggests that we should ask for their input and see what are their goals so that we can design the treatment and assessment for them from that angle. So this is a really good reading. I recommend everyone to read. So that brings back this concept again. people first and then patient. So we should always ask our patient, what's most important to you and what concerning you the most. So that's why we can use our framework here. So we're going to talk about this framework, each domain of this framework now. The first domain we can just quickly go over is basically the impairment domain, because we all very familiar with this domain. It is basically centered on the physical changes from the dysphagia. What we can do to assess and treat in this domain is we are all already very familiar with the clinical or instrumental swallowing evaluations. And for the treatment, we can do diet modification. We can teach patients to use swallowing maneuvers. There's also exercises we can do. There's strength-based, there's skill-based stretches, or there's manutherapy we can use. So there's a lot of tools to address this domain. Also, we can, like Heather mentioned before, there's a lot of patient-reported outcome measures that we can use to address those questions, and we can ask patients and family in the interview for the specific impairment. But these outcome measures are also very helpful to address other domains, not just the impairment, which we're gonna talk a little bit more later. So now we are going to talk about the participation domain, and this domain focuses on the patient's involvement in meaningful activities. Basically, thinking about patients with dysphagia, they may have challenging going out to eat because they feel embarrassed. Maybe they are drooling, or maybe they can't eat quickly. They have to cut food into small pieces. So those are the challenges that prevent them to go out in the social activities or social settings. What we can do is we can ask the patient or ask the caregivers about, what is the barriers and how can we help them. So some people may clear their throat a lot in the, because as a strategy for swallowing to improve the swallowing safety, but that may not be good if it's in the COVID pandemic, because people may scared and then they don't want to be with the patient that coughing or clear through a lot. And then some people after, because we work with head and neck cancer patient a lot, after their oral cancer treatment, they may experience drooling. And one of my patients actually has that problem, and then she just refused to go out in public. And she also she doesn't want to eat in front of her husband because she just feel like it's very embarrassing for her to do that. So for assessment in this domain, these are the same patient-reported outcome measures that we can use: the SWAL quality of life survey questionnaire, and then the performance status scale head and neck cancer, and then also MD Anderson dysphagia inventory and dysphagia handicap index. So for the SWAL, there's a specific section focused on just the social functioning. There's 10 different concepts in this whole tool, but this is the specific one for public eating. They talk about leisure activities, and then talk about social gathering. Also for PSS-NH, there is a section just focusing on rating the public eating. Same with MDADI. The first question of this survey is talking about my swallowing ability limits my day-to-day activities, and that is also the participation domain. And then dysphagia handicap index too. They have 3 domains in this whole questionnaire: physical, functional, and emotional. And these are the questions that focus on the participation domain. Okay, so for intervention, for this domain, we first need to acknowledge that all the patients are facing the challenges and let them know that they are not alone. And then it's critical to focus on this collaborative problem-solving approach so that we can help them to identify location, people, strategies that will help them increasing their social participation. So for example, you can ask the patient, if they don't want it to go out for social event with strangers, maybe they can just start with like social gatherings with people that they know or their friends. And if they're not comfortable eating with others, they may just consider eating beforehand, before going to a social event, so that they don't have to be embarrassed or focus on eating when they're social with other people. Jocelyn has a patient that's very brilliant. She wants to go to an event with friends in a restaurant, but she's afraid that there's maybe issues with the dysphagia during the event that impact just her participation. So she actually chose the restaurant and then went to the restaurant the day before to order the pizza that she wants to try. And so she actually had the pizza there and try it out so that she feel comfortable next day when she's there with other people and ordering the same thing. So those are the ideas we can use and try to help patients to brainstorm. And the next domain I want to talk about is environment. So the environment domain is it has a lot of factors. It can be the availability of appropriate food textures or liquid consistency across different situations, like if there's easier texture in the restaurant available for patients to order, and also include the attitude and level of acceptance and support the patient can get from family, friends, or strangers in different situations. Again, the same thing, just like, if it's during the COVID and if they're coughing or clear throat as a strategy, well, the people around them accept that. And also this attitude, this acceptance also depending on the cultural preference, because that's also a big factor. Some culture or some environment, they prefer certain textures or certain portion of the food. And if, they're in that specific environment, is that friendly to those patients? And then also this includes the attitude for the healthcare professionals and public, because dysphagia is invisible, so we can't really see it just from outside. And sometimes the doctors or the healthcare professionals may overlook that impact on the quality of life. So they may not provide appropriate referrals, or they may not provide appropriate intervention for these patients with dysphagia. And then also on a larger scale, there's healthcare services, systems, policies that may impact this participation, such as, environment, such as if the insurance can pay for the dysphagia services, how much they can pay for, how many sessions they can get. So these are all the factors for the environment factor. And for assessment in this domain, again, you will see the same patient-reported outcome measures we can use because they target many different domains in this framework. And also we can include these questions in our patient interview, such as their living and social environment, their preferred eating settings, preferred food textures, and then also available support system. And for intervention in this domain, we can, again, a collaborative effort to help patients develop strategies to gain some access to needed textures. For example, if they go to a restaurant, check the menu beforehand to see if there's available texture for them. If not, can they bring their preferred textures to the restaurant or to the social event? Also, we can consider some dysphagia-friendly commercial snacks. There's one that's available here in the US called, it's a transitional food. It's called Savory, and some people, if they're craving for crunchy type of food, but they're not on regular diet, they can probably try this snacks out. And also we can brainstorm some ways for patients to gain some support from others in the social situations, so we can empower the patient to really educate people around them in the setting, so like explain to them what is dysphagia, what is the impact on dysphagia, and why they have to eat this way so that people can accept them. And there's again, I think increasing the awareness of dysphagia is really critical. And it's also not just the patient's responsibility to do that. Also, as healthcare professionals, as SLPs, we should also try to help the public, the community to increase the awareness of dysphagia. And there's an article from Asha Leader I want to share here too. It's called Dining Out with Dysphagia. It is a pilot program from University of Cincinnati. They have this project to help restaurants to expand their menu so that they have more options for people with dysphagia that they can order. So that's a really cool project. And also for patients living in the facilities, it's really important to ask the staff to advocate for better feeding assistance. And also, if they're on puree diet, can we make the food more appealing, like using food mode or 3D printed food? And those are pretty new technique nowadays available. The next domain I want to talk about is personal. This domain, first, let's look at this quote again. So basically, there's these type of social cycle responses that mentioned here: anxiety, shame, embarrassment, fear, and reduced self-esteem. And these are the factors that are related to personal factors that relate to dysphagia. So we are looking at patients, the people's identity and emotions, and that include demographic information, personal traits, eating styles, their emotion and coping styles, and then also it's very heavy on culture preferences, because the person with dysphagia, they may not have the same personality or the traits or hobbies that they had before their treatment, before they had dysphagia, and that may cause these anxiety and embarrassment for them. And eating and drinking is very individual. Like in my culture, I prefer food than anything else, because we literally say that food is the god of the people. And wherever I go, the first thing I look for is restaurant, and I would like to have, enjoy my food everywhere I go. I just can't imagine if I couldn't eat or I have to be, on a modified diet. But food may not be priority for certain people or other cultures. So it just really depends on the person and the culture. And then there's a good example that I always share with other people. There's two patients in my clinic, one with oral cancer and had like a pretty big resection. And then after the surgery and radiation, she basically, the tongue mobility is really limited. And then she really just can only eat like soft foods and very, very small bites and slow rate. But she actually felt fine because she was like this before. She always prefer like soup and noodles and soft food. She always eats slow and she always takes small bites. So for her, the change was not that dramatic for her. And so her quality of life after treatment was still pretty good. But another patient, same oral cancer, very minimum impact from treatment. And the only problem was some mild trismus, just the difficulty open the mouth. And for him, he loves like biting his burgers and sandwiches, double. It's like, that's his favorite, that's him. But after the treatment with, the impairment from the oral cancer, he could not bite burgers anymore. He has to cut them to small pieces. And he just felt the quality of life just dramatically decreased. And he was not the same person anymore. He felt embarrassed eating in front of family and friends. So that just tells us, you can have patients that probably the same type of impairment or same level of impairment, but their experience can be totally different. I think Heather also mentioned that before. So it is really, the personal factors matters a lot. So when we are treating patients, we definitely need to get to know them, know what's matters to them. And here's the same patient-reported outcome measures that we can use for assessing this domain. And then for patient interview, what we can do is ask their eating habit, ask their style, portion, preferred food and liquids, and also to see what's the preferred communication support, and then also see if they have fears, concerns. Some people may be really like optimistics and they can handle and cope really well. Some people may not. So with those, we may need to refer them to additional support. And then also to see if they are motivated to eat, if they need additional support. And intervention-wise for this domain, what we can do is, as speech pathologists, we provide supportive listening, let them know that they're not alone. And if they really need more support from other professionals, we can refer them to social workers and counselors, psychologists. Another thing we found really helpful is to connect people with other people with dysphagia through either one-on-one mentor program or through support groups. So here just resources that I'm actually part of. This is the Bay Area Swallowing Support Group. I co-founded this with my co-founder, Claire Heitlinger, and we started this last year, and we're hosting meeting every other month for people with dysphagia and their caregivers. So if you or your patients wants to join us, we'll welcome everyone. It's online. And if you are not in California, if you are in other states and you want to find other support programs, you can always go to a National Foundation of Swallowing Disorders. They have a website with all the different support groups around the country. And then also just a quick refer to one of the articles. I'm one of the author to talk about the swallowing support groups, the benefit of that. If you're interested, feel free to read it. It's a quick read. Okay, and then the last factor for this domain is the caregiver and family domain. It is very important because the patient is taken care of by the caregiver and family, and how they interact and how they take care of the patient can affect patients' four domains. And then also on the other hand, we also need to consider the caregiver and family's four domains, their participation, their impairment, their personal factors, and their environment. And a quick tool I want to share with you here is this caregiver analysis of reported experience with swallowing disorders, CARES tool. This is a quick screening tool developed by Dr. Shun and colleagues, and you can use it to explore, to ask caregivers to see if there's any caregiver burden associated with dysphagia. And for this domain, what we can do for intervention, first we can provide family and patient education and teaching, and sometimes the family members are the ones that actually help patients to implement those strategies in those other domains. And also, if there's any issues with their relationship or marriage, we can always refer them to family and marriage counseling. And also, there's support groups for caregivers too, so they can benefit from that support. The last thing I wanted to talk about, also it's a big challenge that everyone as clinicians or patient and family may face, is the eating with risk. Because we know that, there's patients with profound dysphagia that may not be able to eat because of safety concerns, but they really want to eat. So as clinicians, we need to help them to weigh the risk and benefits based on the domains that we just talked about. And that can be really helpful to guide that conversation. And then we need to make sure that we can fully inform the patient with and families with all the information, risk and benefits, so that they can make the best decision for themselves. And also here is a good resource. Jocelyn and I, we actually took this training, serious illness conversation. Fortunately, we have this training here at Stanford, but it's available if you go to this website. It's basically a guide for you to coach you how to have a conversation with patient and family to find their goals and to honor what is important for them. So I think that's really good to check out. So that's about our talk on the swall from. This is another view of this domain, of this diagram. And if I know the time is really limited today, so if you wanted to know more about this topic, Jocelyn and we actually did a podcast with Aphasia Access with our colleague, Alan Bernstein Ellis. So if you are interested, this is the QR code. You can scan and listen to it. And that's the end of our presentation. Thank you so much. This is our contact information if you want to talk to us.